I'm super excited to be with everybody once again to talk with my friend and colleague, Dr. Christian Jenski, about all things functional medicine. And today we're going to take a deep dive into metabolic syndrome. We were talking before we started recording here about metabolic syndrome, what it is. And I think people are hearing about energy, having adequate energy, having good energy, hearing about mitochondria, a bunch of things. And when I talk with people, I don't think they understand the scope of metabolic syndrome, which is primarily an issue of energy production, and it looks like a lot of different things. So what we're going to be doing over the next 3 sessions is talking about metabolic syndrome, like just listing off what are some of the things you see in metabolic syndrome, then taking a deeper dive into individual ones, what are some lab tests you can look at, and then at the end, talk about mitochondria, what they do, like how can you actually address some of these things. Because ultimately, we talk about diet, we talk about lifestyle, we talk about toxins, a lot of things that play into this. But ultimately, to get to the root cause, you really need to kind of know what's causing your energy production issues. And if you don't have an idea of what could be going on, it makes it hard to kind of get to the root cause. So I don't know if you have any introductory remarks before we start diving into some.
No, I think that was good. I think you kind of hit the nail on the head, which is to say that metabolic syndrome, I think, falls into this general bucket that most people have some semblance of an idea about. Like, okay, it's an issue with your metabolism. So maybe for that person, it means I'm gaining weight or I feel tired or, my brain's not working as well. But the layers are so deep and the problem list gets bigger and bigger and bigger the more we understand this. And I think there are things that people don't really realize are still classified within that confine of metabolic syndrome. So the whole point of all this is to kind of uncover that and delineate what some of these things are, because I think it'll then resonate with more people to see just how ubiquitous this is and how much, like when you talk about things like inflammation as the root cause of all evil, so to speak, or mitochondrial dysfunction, this is that playing a role, and it can kind of be that common thread to all these different parameters of health or disease that tie it together.
And like in going on, like thinking that, like the reason we talk about metabolic syndrome is because we have a research-based criteria. And so when someone says metabolic syndrome, this is according to the NCPT. So this is a national guideline that cardiologists and endocrinologists and family practitioner, internal medicine people use. And we're just going to go through these really briefly. And this is how we define metabolic syndrome. And I want to start with the definition and the concept of how lacking the definition is, especially when you dive into what diseases are in that. So, first thing is obesity. If you're central obesity, particularly, you hear the weight around your
Spare tire, the waist
which
circumference.
correlates with fat around your internal organs. Visceral fat is the term for that. It's interesting how some ethnic groups will hold more visceral fat than others. Asians, for example, will hold more fat around the organs than their skin. So you can see someone who looks skinny and be metabolically obese. Versus on the other side, African Americans will actually hold body fat more on their skin, so they can look overweight but not have as much visceral fat. And then Mediterraneans, Middle Easterns, and Northern European descent individuals are between these two spectrums. But just realizing that can help you understand how you can have someone who's from India, for example, or Bangladesh, or Nepal, which I've had patients from all these areas who look to be healthy and they're diabetic, pre-diabetic, So it's particularly for men, your waist is greater than 40 centimeters, women greater than 35. Why don't you talk about the next one, which is triglycerides, over 150.
Over
And talk about
150.
that a little too.
Yeah. And interestingly enough, like this condition, this diagnosis, this criteria, this didn't exist when we were in medical school. Like this kind of came to pass while we were coming up. Like it was metabolic syndrome doesn't predate that. It's something that's developed over time, secondary to all the trends that we've seen in, lack of exercise and sedentary lifestyle, poor diet, not managing stress, not managing other hormones, not sleeping appropriately. So metabolic syndrome, I think the reason there's confusion or lacking in clarity is because it's kind of relatively newer. But triglycerides greater than 150. So triglycerides are part of the lipid profile that we look at when we're trying to risk stratify somebody for cardiovascular disease. And there's cholesterol, there's triglycerides, there's HDL, and there's LDL. And the HDL and the LDL, that's the good and the bad cholesterol, total cholesterol, and then the triglycerides. Triglycerides greater than 150, for us, greater than 70 is deemed to be too much. I mean, really, this is the difference between normal and optimization. If you have triglycerides less than 150, you don't meet diagnostic criteria for metabolic syndrome. In my practice, it's not optimal. We want those less than 70. So there's even these hallmarks as part of the criteria that, again, like many things in conventional medicine, the range is too big because it's predicated on the general population, which is overweight and obese, or overweight and diabetic and metabolically inflexible. And so that's a problem. But there's many factors within triglycerides. The next one, like things like diet, lack of activity, genetics, these are all things that are playing a role. And then the next one being HDL, which I just alluded to, which is good, deemed to be good cholesterol, but that even has layers. And so if your HDL is low in men less than 40 and in women less than 50, that's part of the criteria. And then what are the next two?
Well, blood pressure greater than 130 or 85, and a fasting glucose over 100. So if you have, at least 3 of these, you have metabolic syndrome. But then taking a little bit of a deep dive into, blood pressure, if you're, blood pressure 130 over 85, again, not optimal. You want your diastolic probably, a little bit less than 80, your systolic in the 120s. Fasting glucose is interesting because we know if you're fasting glucose, I believe it's 86. If it's over 86, for every point it goes up over 86, you have a 6% increased chance of developing diabetes.
In the next 10 years.
So do I want 80 or 70 or 98, right? Or 99? So all of a sudden, when you hear metabolic syndrome, you have to realize it's a very limited view. So which goes into the next section. I'm just going to read through the list first of illnesses.
It'll be
so
these are the associated
diseases.
Yeah.
And when I mention these diseases, you have to think about, okay, where does that fall into this diagnostic criteria he just mentioned before? And the answer is many of them do not. Okay. Obesity, of course, type 2 diabetes, cardiovascular disease. And when you realize half the people who go to the ER with the first heart attack have normal cholesterol, well, what's the marker for that? Non-alcoholic fatty liver disease, which now is called metabolic associated fatty liver disease. Fatty liver, basically the concept is with some of the triglyceride issues, your body can't appropriately store and move around fat. And so let's just put it in the liver and see what happens. And it's interesting how many...
Uric acid does that too, which we'll talk. Uric acid does that too.
And one of the things that's interesting about fatty liver is that, early in my career, I would see patients, we do it, liver pain, whatever comes in. They don't have diabetes or pre-diabetes, and you do an ultrasound as part of the workup. I mean, in the year, how many people would you see that comes back with, heterogeneous liver consistent with fatty liver disease, and they're like, okay, well, you're okay, because we see this all the time.
It's one of these things, it drives me crazy, and it's drives me crazy because it's dismissed, and I think less so now, but still not aggressively managed in a way that I think is appropriate. And having a parent that passed away from liver disease, like this is like one of the things that I focus on a lot with my patients. And it's, the way I'd explain it to patients is there's a continuum for everything. Like the best way to understand medicine is to just look at it in simplistic terms. And so if you look at fatty liver disease or liver disease in general as a continuum, all the way to the left, no liver problems, no risk, liver's functional, everything architecturally looks okay. And then you start to have a little bit of liver injury patterns. So you start to see elevation in liver enzymes. It's called transaminitis. Those cells, those hepatocellular hepatocytes, the cells themselves, as they start to kind of lyse or break open, they'll spill these enzymes into your bloodstream. You measure that. So we see an injury pattern. Then there's fat deposition that gets put down. So we start to say fatty liver disease. Then you start to see a little bit of early scar tissue we call fibrosis, then mid-stage, then late stage, and then you're cirrhotic where your liver's failed and it's completely scarred down and it's irreversible, as are the later stages of fibrosis, even pre-cirrhosis. And so when someone says, oh, you got some fatty liver disease, you're already all the way here on the continuum. Like that should be a flare gun going off saying, hey, we got to do something about this. Now, in that individual, is there a lot of low-hanging fruit? Do we need to lose some weight? Do we need to get exercising? Do we got to clean up the diet? Usually yes to all of those things. But what if they're doing all that already? Then where do you go? And that's where this gets complicated and layered, but you got to do something about that because the next step is the beginning of that burgeoning irreversible process, right? And we used to call these things incidental lomas, right? Somebody would come to the ER and the reason for whatever imaging you're getting is unrelated to what you find in the imaging. An example would be someone has right lower quadrant abdominal pain. Okay, I push on it, they wince, there's rebound, their white count's up. I suspect appendicitis. Get a CT scan. no appendicitis. Great. You don't have appendicitis. Urine's clear. I don't see anything concerning. You can go home. Oh, by the way, we saw incidentally that you have fatty liver disease on your CT scan. Follow up with your primary care doctor. And they may or may not. And if they do, that primary care doctor might just be like, yeah, try to lose some weight. But that's it. So you see it over and over and over again. It's common and it's everywhere.
And we'll talk about in part 2 about specific
each specific disease, what to
therapies.
do
Because
about
I've had patients have their fatty liver disease go away, have the fibrosis score, the elastography normalize. So
my fatty liver went away. I mean, I had fatty liver disease.
There are things we can do about this. Gout. Well, I'll talk about PCOS and you talk about gout. PCOS, polycystic ovarian syndrome, is interesting because I don't want to talk too much about it here, but part of that is insulin resistance. When you develop insulin resistance, which is a part of metabolic syndrome, you get it in every organ in your body except for 2. One of them is your ovaries and one of them is your kidneys. So what happens is when the insulin goes up, you retain fluid, you can get blood pressure issues, and you get overstimulation of your ovaries, and which can result in hirsutism, excessive amounts of testosterone, but as well you get these cysts, and it's a big cause of infertility. It's a part of this metabolic syndrome thing. Talk about gout a little bit, because I don't think people really think about gout and the excessive amount of uric acid, and how that correlates with.
Yeah. So I think I would say gout / elevated uric acid, because you can have elevated uric acid and not have a gouty arthritis presentation, and that's still a metabolic disease as far as I'm concerned. It's a harbinger of things to come. Like, we weren't paying attention to uric acid as much as we should have unless that person had gout, right? Pain is a motivator. Someone has a red hot inflamed big toe, that's called podagra. That's usually the initial presentation of gout. And so they go to their doctor, they get put on some NSAIDs, some non-steroidal anti-inflammatories, maybe some steroids, maybe a gout-specific drug like colchicine. And then they're like, all right, clean up your diet, eat a lower purine diet, don't eat a lot of, red meat, don't drink beer, that kind of stuff. But what they don't ever get counseled on is don't eat a lot of fructose, don't eat high fructose corn syrup, don't eat sugar, even fruit that has fructose in it. The things that are going to drive fructose up in your body are going to drive up uric acid, which is going to drive up metaflammation. It's going to hurt the liver, deposit fat. So uric acid, again, much like everything else that we measure, is within a normal range, but we have a range that's optimal. It needs to be below a certain number. And so when your uric acid starts to trend up and it was previously normal, that might be an early indicator that you need to clean up your lifestyle or do something different about your metabolism, because it may be going in the wrong direction. So I see uric acids that are too high and that person does not have gout. I see uric acid going along with gout. I see people with a gout flare that have a completely normal uric acid. In the flare setting, that's often the case. So you really have to look at it through the lens of, what is this trying to tell me and how does it fit the bigger clinical picture of that patient? But this is one that I think is really, really important as kind of an upstream clinical indicator of what else might be going on. And so I get a uric acid on every single patient. I'm pretty sure you do too.
Yeah. And if uric acid level is greater than 6, you're still accumulating it in your tissues, whether or not you have flares. And that's we'll talk about that a little later on, but that's
the gout, it basically causes these crystals to essentially deposit into the joint space and form or cause an acute inflammatory arthritis, right? That's essentially what's happening. You see it in the toe, see it in the elbow, see it in the knees. Those are most common presentations. But I mean, like, that then kind of lends in, and we'll get more into that, but that lends itself to, in my opinion, also a harbinger of cardiovascular risk. Even like part of Dr. Mark Houston's protocols for reversing cardiovascular disease and decreasing plaque burden is that he puts patients on allopurinol or colchicine if their uric acid levels are high and their lifestyle is not managing it. So there's utility for these medications, but this is stuff that can be correctable with other things, right? What about kidney stones is another one. You want to talk about that, and sleep apnea. I know you have lots of thoughts about sleep
kidney
apnea.
stones, it has to do with oxalates. It can be from too much oxalates in your diet. Sometimes, we actually do it to ourselves by eating too much kale or doing green smoothies, which are high in oxalates. And in nature, what's supposed to happen is when you eat these foods, you actually eat calcium with them, and the calcium binds to oxalates in your diet, and you just poop them out and you don't absorb them. The other source of oxalates can actually be yeast in your GI tract. And so when you see people with elevated oxalates, and I've had patients who've had that and have their gut testing shows your yeast levels are high, then all of a sudden, in order to get the oxalates down, it's not just, taking some calcium citrate or magnesium citrate with a meal to minimize absorption. It's also dealing with your gut to actually minimize yeast and other bacteria there's actually certain bacteria that actually break down oxalates. And so we do all the gut testing. So gut microbiome, yeast overgrowth, but ultimately, and we'll talk about this a little bit later, your gut microbiome is a big part of this. But the point is, like, this is not oxalate levels, uric acid levels, sleep apnea screening aren't any part of the current diagnosis criteria
Right, PCOS.
for diagnosing metabolic syndrome. And when we'll finish the list and go back, but one of my things, if someone has anything on this list, all of a sudden I'm looking for all the buddies. I'm looking for the crowd. I'm looking for the gang that comes with them. And it's amazing. You'll find, you do organic acid testing, your oxalates are elevated. Oh, your uric acid level is 7.7. Oh, you snore a little bit at night, and all of a sudden it's like
the picture
fits, and all of a sudden it's like I'm treating all of this. Sleep apnea is one of my pet peeves because I feel like it's very common and frequent underdiagnosed. Because the definition of, when you do this thing called an ARIES evaluation, you look at how thick the neck is, usually men, you look how thick the neck is, you look at their BMI, their weight, do you snore, does someone see you awaken at night, and if you check enough boxes, you can get a sleep apnea evaluation. When I see my patients, I'm looking at facial structure, looking at how big their tongue is, if they're hypermobile. When someone goes, can actually see the back down. Is their tongue too big? They can't see this, But sleep apnea is a part of metabolic syndrome, and there's a close association with sleep apnea and low testosterone, especially in men. We know low testosterone and men can be associated with cognitive decline. Strangely enough, in diabetic, and we've known this for over 15 years. I mean, this was the drug reps when they used to come around my office would sell me on giving testosterone to my diabetic patients because the literature was out there that if you're diabetic, check low T, and your T low, that affects your progression of diabetes. But we're not going to deal with the metabolic stuff, right? And so it's interesting how just one of those strange things that the drug reps come into the office to sell me a testosterone product after an article came out because there's a product to go with the article. But when they talk about gut microbiome stuff to go on all these, no one's coming by to sell me probiotics or to have me sell patients, probiotics or whatever. So,
and it's also downstream. I mean, giving someone tea then shuts down their supply, doesn't get to the root as to why the tea's low to begin with, and you may be short-term helping them, you're not long-term.
That's one of the things in one of the groups I'm in. I'm in a business networking group, and you hear people talking about low T a bunch, and never do you ever hear them talk about metabolic syndrome. They're getting on T therapy, or they're getting peptides, they're getting testosterone. They feel great, and it's like, well, who looked for metabolic syndrome? Who looked for all these other things? Where you screen for sleep apnea, and sometimes like, oh yeah, last year I got checked for that, but don't treat it. I'm like, no one told you that's probably one of the reasons why your testosterone is low?
Yeah, it doesn't make any sense. I mean, we didn't know, and I don't know that it even matters, whether low T was the result of metabolic dysfunction and syndrome or the harbinger of metabolic dysfunction to come, because you can push your T down in a variety of different ways: chronic stress and cortisol elevation, biotoxin injury. So it's not always the direct result of, it could be the harbinger of metabolic dysfunction or whatever to come. But that being said, like andropause, which is emerging as this like new thing, shouldn't exist. And we're seeing it all the time. Like evolutionarily, men should be able to make testosterone for the duration of their lives. And now we're seeing guys in their 20s and 30s with low T. It's like this epidemic, and it's insane. Clearly this is a problem, and it's related to all this. Going back to the sleep apnea thing, like their Mallampati score, their oral architecture, their ARIES score, whatever the questionnaire, all that aside, if any of my patients have any of these and they've never had a sleep study, I order a sleep study. Like, it doesn't matter if they have a thick neck or what their mouth looks like. I'm doing that as part of my full metabolic.
And personally, in my personal belief, this is Dr. Hartman's belief, I feel like if you're 50 or over, you should get a sleep apnea.
At least once.
It's like if you get 50 or over, you should get a coronary calcium score, right?
And a colonoscopy.
Well, 45 for the colonoscopy because cancer is coming earlier now.
Well, I just turned 50 and I'm getting my first colonoscopy.
I got mine at 51, so I was a little bit, but it was clean. It was clean.
I did Cologuard when the new guidelines came out. I was 46 and a half when the guidelines dropped it to 45. So I did Cologuard. It was negative. Now I'm newly 50 and I'm going to go ahead and get my scope. Yeah. And then hopefully they'll say see you in 10.
Yeah, and then you don't have to worry about it. My recommendation would be the SUTAB, because
SUPREP is what I got.
SUPREP unfortunately has sucralose in it. Yeah. The sweetener in it is Splenda. You know who told me that? My wife. I got it from mine. I'm like, oh, I did it, and with her, she has these eyes that see things. I'm kind of rushing around. She's like,
Yeah.
"What's this thing right here?" I'm like, and I was in the process of doing my prep, so I couldn't reverse
Yeah.
it. But the SUTAP is just potassium, sulfate,
Mag. Osmotic
yeah, it's
laxative, right?
potassium, sodium, magnesium, sulfate,
Yeah.
and magnesium
Mhm.
sulfate is Epsom salt. So it's kind of like a prescription fancy version of Epsom salts
Yeah.
that are
Yeah.
and then you just
Detox.
basically drink a lot of water.
It's a liver
Don't do it if
flush.
you're old, if you have POTS or dysautonomia, because
Yeah.
if you don't drink enough water, you will get dehydrated and then you won't get it done. So it's
Yeah.
that's one of the reasons why some of the GI doctors don't like it, because if you don't drink enough water or you're elderly or chronically dehydrated, that could cause some problems. That's the little
Yeah.
anyway, moving on.
What about dementia? What about Alzheimer's
It's really
disease?
interesting. Alzheimer's disease is now being referred to as type 3 diabetes.
Yeah.
Well, why is that? Because the insulin resistance stuff. And when I did my Bredesen protocol training, there's like type 1 through 5 Alzheimer's, but type
Subtypes, yeah.
but type 1.5 was glycotoxic. So
Yeah.
it's there's a correlation with mitochondrial dysfunction, with insulin resistance, with metabolic syndrome, and with Alzheimer's. So if someone's having cognitive decline, look for all these things in metabolic syndrome.
Right. Not to mention the fact that neurons, your brain cells, can utilize ketones as fuel. But the supporting cast, the glial cells and the astrocytes, what do they like? Glucose. If you have insulin resistance, they're not getting their glucose, and that's a problem. What are they doing? Housekeeping. You're not getting housekeeping, you develop, senescent cells, you develop amyloid plaque buildup, you start to get neurofibrillary tangles. Next thing you know, you have cognitive decline, or that usually precedes it, but you know what I mean.
Yeah.
And then what about chronic fatigue, and what about mood disorders? Like, how would mood disorders fall into the realm of metabolic
the
syndrome?
thing about mood disorder, so chronic fatigue, we'll say, I feel like we talk about this so much, I don't want to belabor the point, but
it just
it's a
fits.
metabolic.
I mean,
yeah.
we'll probably hit that when we do the mitochondrial part.
But this is one of, one of my, how is the way in which you interpret the data, the labs, your science, ethics, the world around you? What's your worldview is the term for that, And one of my worldview glasses I put on when I look at literature and look at labs is, what were people doing 1,000, 2,000, 3,000 years ago? Maybe I don't understand Ayurvedic medicine or traditional Chinese medicine, but people saw patterns. They noticed nuances, and it's interesting how how has that changed over time, And so that's like the traditional thing. It's been around for thousands of years, and then you have the modern things, and in our in the ER and family medicine and even in functional medicine. What are we doing now that we've done for more than 3 or 5 years? I mean, I manage migraines radically different than I did 10 years ago. I manage chronic fatigue and fibro different than I did 5 years ago. So the first question I have in traditional medicine, what are we doing now the exact same ways we were doing in the 1950s? And the answer is mental health. The neurotransmitter theory of mental health disease came out in the 50s. And we've been basing all of our therapies on it since then. And we have not had breakthroughs in mental health. Well, come to find out, we learned out when we did our mold training, there is a subset of people with bipolar schizophrenia that actually it's the neurotoxicity from mold and the associated people. With mitochondrial dysfunction, it can obviously affects everything else, but it can affect your brain function, which in some people can look like anxiety, depression, mood lability.
Well, it also affects neurotransmitters, so clearly it affects
all those things. Yeah. And so if someone comes in and they have mood instability, anxiety, depression, OCD, ADHD, schizophrenia, bipolar. Yeah, there is in schizophrenia and bipolar, there is a genetic component, but that is the vast minority of individuals. Then I'm thinking, do you have a mitochondrial metabolic kind of thing?
Inflammatory.
Yeah. And a lot of the treatments are very similar, but there's, for great example, there's a drug called Deplin that is FDA approved to treat severe recalcitrant depression.
And it's a very high dose of
folic acid,
methylfolate. It's a B vitamin.
B vitamin,
B9, but it's premethylated. I have a patient who has an MTHFR SNP, who was severely depressed and anxious, saw someone was put on Deplin, and immediately was normal.
Not to say they're all the case.
Having symptoms.
Not to say it's all the case, but a lot of these are symptoms. You get this symptom cluster, your depression, this symptom cluster, your anxiety, this one, your ADHD. And finding out is there a metabolic component is huge, because many of them do have a metabolic mitochondrial component. And the last one we talk about is cancer being a
This is the one that no one really talks about as much
yeah.
as they
Well, I
should.
actually interviewed Dr. Seyfried, who wrote the
Yeah,
textbook on
that's-
this, you know,
yeah,
and
great.
back to the, you know, it was interesting. When back in the 20s and 30s, they were having research showing that cancer actually was an issue with energy production. The cells stopped using oxygen and would actually start using glucose for energy and create acids, lactic acid, which one of the biomarkers I use with my integrative cancer patients is looking at LDH. Is that elevated? You know, um,
It's called the Warburg
yeah,
effect.
Warburg effect, correct. And so, but what happened was is we discovered genes, and all of a sudden we forgot about the metabolic aspect of cancer.
Yeah.
And how you know, you look at cancer, you know, cancers have disappeared in the last 7 years. We've cured them all. They're all gone away. Our treatments are perfect. No, it's more common, getting younger and younger and younger. And we're realizing there's definitely a metabolic component to it. You know, when you hear about cases of a glioblastoma, which is like the most aggressive brain tumor, they were actually treating those at Hopkins in the 20s with ketogenic diets.
Mm-hmm.
You know, what's a ketogenic diet? Going back to what you were talking about with energy, you know?
Yeah. So basically eating a higher fat, high protein, really low carb sugar diet so that you're into a state of ketosis where your body is essentially using ketones as fuel, more efficient, more sustainable, and it's going to turn over cells better. So you're getting better autophagy, you're getting better apoptosis, not defective apoptosis that we can sometimes see. You're having less senescent cells, you have less inflammation, you can detox. You tend to be feeding the good cells like your brain and not cancer cells. You tend to starve cancer when you're in a
One
ketogenic
thing
diet.
just popped in my head when you were saying that, and I don't know the answer to this question, so I'm going to ask you this right now. What you're saying, it makes sense that metabolic syndrome might also be a senescent cell issue because senescent cells are dysfunctional mitochondria. Are you familiar with literature in the metabolic syndrome world specifically referring to senescent cells? Because there are therapies for that as well. Are you familiar with that?
With a tie
Yeah,
between the
with the
two,
direct, like,
not any specific study, but I can almost guarantee you if we did a PubMed search right now, we would find a link. I mean, it's one of those things where these are the common threads that we see over and over again. Do I know of a case report that's out there that proves those two or links those two? No, but I'm sure that there are. I mean, like senescent cells are zombie cells. What are they doing? They're dysfunctional cells that are infecting adjacent healthy cells. And we have cell senescence our whole lives. When we're young, our immune system identifies it and clears it out. As the immune system ages, and there's more emerging literature on your true biological age is most closely linked to the age of your immune system. As your immune system is aging, you're less equipped to clear out senescent cells. So you have more of them, and they are therefore infecting or affecting adjacent cells. And that just becomes this cascade of events that now you're starting to have organ dysfunction and damage. And so to me, that's kind of just a different way of saying metabolic dysfunction. I think they're tied together.
So I want to close things out with this. We just talk about the big thing. The point of this is metabolic syndrome, energy production issues, not creating enough energy, not having enough good energy, includes a lot of diseases. And just checking your sugar, just looking at your A1. This actually didn't even mention A1Cs and vitamin D levels, and we'll go into that later, right? But you really need to take a deep dive and looking at these other associated issues. If you have energy production issues, if you have metabolic syndrome, you need to look at the bigger picture as do you have markers for any of these other things? And we'll dive into that a little later. But that's my takeaway is that you have to look at this whole group of metabolic illnesses. Yeah. If someone has one of them, I'm looking for the buddies. If there's smoke, I'll look for the fire. And then we start addressing those. And lo and behold, people feel better.
If you have one of the conditions or suspect you have one of the conditions on this list or more than that, and your doctor hasn't done a deeper dive on your metabolic dysfunction, then you need to see somebody else. You need to see somebody that will, because there are more answers to be uncovered that can help you resolve those problems, bare minimum manage them better, and determine if there's something else that's on the horizon that you're not expecting. Why not get ahead of it? Why not be proactive and preemptive?
We'll talk
it?
on the next one, the one after that, about some easy treatments for each one of these that can be super helpful. But if you have fatty liver disease, for example, and you're not on TUDCA or ursodiol, like that's where all the literature is going right now. And like at the highest levels at NIH, and it's like most people are like, huh?
Secondary bile salts.
I can use that.
That's what it is.
Yeah. Just
or vitamin E, or milk thistle, or a host of things.
SAMe,
versus,
PC,
hey,
phosphatidylcholine.
Right, you have some fatty liver disease. Walk
lose
it
some
off.
weight. Get on GLP-1. Lose some weight. And actually, I remember early in my career, patients were getting referred for gastric bypass to treat this. because weight loss was the optimal thing, and you don't lose weight for your fatty liver disease. So let's do bypass surgery.
I mean, that's like the opposite end of the spectrum
Yes.
versus doing nothing. Let's get as aggressive as possible. I think there's a
I-
middle ground.
Agreed, my friend, agreed. So let's stop there. Hopefully this information was helpful, talking about energy and metabolic syndrome. If you have questions, please post them in social media where you're looking at this. And next time around, we're going to dive into these individually to give you some more information about energy production and metabolic syndrome and all things related to that. Take care, and we'll talk to you soon.